in the Western Cape. So thanks very much for participating this afternoon, Anna.
Thank you very much, Graham. It is jam-packed, so I'll go straight into it. So the first slide. So this is the Western Cape COVID-19 epidemic to date, and I'm sure members of this audience are very familiar with this graphic. So if we look, these are all the metrics we're tracking, including oxygen in green, hospitalizations in blue, deaths in red, positivity, test positivity in yellow, and cases in the gray bars in the background. All metrics are clearly tracking up for the third wave, and we can clearly see the first, second, and heading towards a peak on the third wave on this graph. If we look at deaths and the test positivities on the secondary axis, and the test positivity has breached 30%. Not on this slide, but just to note that currently our 7-day moving average for new diagnosed cases for the province is around 2,000 a day, new admissions around 300, and deaths sitting at an estimated 68 per day. If we go into the next slide. We see the comparison of the three waves in the Western Cape. So the top graph looks at the Western Cape as a whole. The light blue is the first wave, the dark blue is the second wave, and the orange is wave 3. If we superimpose them, we can see that we have exceeded the peak of our first wave, and we are more or less tracking along with our second wave. If we separate this into public and private sector testing, we can see that the epidemic in the private sector started earlier, and the slope is now starting to flatten out, compared to the public sector, where the third wave is still rising, and also tracking more or less alongside the second wave. Important caveats to this: we have restricted testing at different times in each wave, and with the third wave this time, we have restricted testing a little bit earlier. And also just to note, particularly for the third wave, the downward turn, we also have to consider data delays, and then the fact that in the second wave, we entered level 3 restrictions quite late in December, and we, comparatively speaking, for the Western Cape at least, we went into level 4 lockdown, and this is our third week of that. So that will also play some kind of role there. Looking at the next slide, we have a greater focus on the sub-districts in the metro. And we can see that the wave patterns differ by geography and most likely socioeconomic lines. Most metro sub-districts are generally tracking above their first wave, but below the second wave. Notable exceptions in this graphic is Northern, where the current wave has been tracking the second wave, and Khayelitsha, that's been below both first and second waves. In the next slide, we're just looking at our reproductive number. And we see that for the last 2 months, it has been sitting around above 1, and currently it's sitting at around 1.2. Along with that, again, the next slide, please. We are looking at doubling time, and we're comparing the first 50 days of the waves between the second wave and the third wave. And we can see that for wave 2, the doubling time was around 13 days, and for the third wave, around 15 days, so slightly slower. But yeah, again, testing restrictions, and we also can't, we also have to take into consideration the level 4 restrictions for the Western Cape specifically in comparison to a place like Gauteng. Looking at wastewater, so this is quite a busy slide, but it is essentially saying the same thing. Looking at the metro, the wastewater plants in Athlone, Kraaifontein, Mitchells Plain, Potsdam, and Zandvliet are all high. Borchards Quarry has seen the highest since the start of the wastewater surveillance in October last year. We also monitor wastewater in Theewaterskloof in Breda Valley, and we've seen increases there as well. Onto the next slide. This is just to illustrate, as I'm sure we're all aware by now, that the Delta variant is dominating in the Western Cape and has been since around the middle of June. And then lastly, just to look at the SA Modeling Consortium picture. The next slide, thank you. So from the Modeling Consortium, you can see that all provinces except KZN are in the third wave. And looking at the 7-day moving average of new cases by province in the top graphic, you'll see that there's a downward trend in Gauteng. We hope it continues, but as mentioned at the top of the call, there has been unrest in both of these provinces. So we watch to see if there is any impact, particularly in these provinces, on COVID-19 cases. That's it from me. Thank you.
Thank you very much, Erna, for that update. As always, really great to get that real-time update of what's happening with respect to the epidemic and the third wave in our province. So we're going to move on to the next speaker, and it's a great pleasure to welcome Professor Cheryl Cohen. Cheryl is a professor in epidemiology at University of Witwatersrand and heads the Center for Respiratory Disease and Meningitis at the NICD. She heads up a team responsible for the national surveillance of respiratory diseases and meningitis for South Africa. And her team has a research agenda in the field of respiratory diseases with a focus on the burden of disease, disease transmission, and risk groups for severe illness, as well as assessment of impact of the effectiveness of interventions such as vaccines aimed at reducing disease burden. And Cheryl is going to share with us today findings of a study that she led called the First C study that has really deepened our understanding, particularly in a local context, of the transmission dynamics of SARS-CoV-2 and infection and reinfection. So really excited to hear this study presented on our forum today. And at the end of the talk, we should have time for 1 or 2 questions. So over to you, Cheryl, and thanks very much.
So thanks, Graham, for having me. Can I just check, can you hear me and can you see my screen?
Yeah, so Cheryl, we're seeing your screen in full mode, but your camera is off. I don't know if you're able to switch that on.
Hang on, I thought it was on. Wait, let me do it again.
Okay, it's not a problem. We're seeing
can you see me now?
We're seeing the presentation and we're hearing you fine.
But can you see me now? I think I turned it on.
No.
Oh, it won't let. You cannot start your video because the host has stopped it. So Graham, if you okay. Someone up there, there we go.
Mark, are you? There we go. We're seeing you fine. That's all fine.
Okay, excellent.
You're seeing you and seeing your slide.
Wonderful.
It's slightly regulated, yeah.
I can see. Thank you so much for the opportunity to present at this meeting. And as you've mentioned, I'll be presenting the results of the First C study. And really just to start off by acknowledging, as you'll see from my presentation, this is an incredibly intensive study, and it's really represents the work of a whole team of people. I mean, on this slide, we just the main partners are represented: the Perinatal HIV Research Unit and the MRC Wits Adjunct Court Unit, who implemented the field work. The team at the National Institute for Communicable Diseases, which did the laboratory testing, and also the US CDC, who funded the study and were also important partners in terms of the analysis. So essentially, First C is a study that built on a previous study that we conducted, which was called the First Study. And the results of the influenza component of that study were published, in fact, just last month. And you can see from the title of the study and the results, the study really looked at the asymptomatic transmission and burden of influenza. First was a cohort study done in a rural and urban community of South Africa, and it was trying to look at the burden and transmission dynamics of flu and RSV. And it was very intensive, and it was completed in 2018. But when the COVID pandemic started towards the beginning of last year, I think it quickly became apparent that some of the questions that we'd been trying to examine related to influenza and respiratory syncytial virus and other pathogens were going to be really, really important questions for COVID-19. And so essentially, early last year, myself and the other investigators who'd participated in First got together and discussed, whether it might be able to implement or essentially restart this very intensive study to look at questions related to COVID. And really, that's how the First C study came about. And this study really has 2 big arms or pillars in terms of objectives. The first group of objectives really relate to estimating the community burden of SARS-CoV-2, and that includes the incidence on PCR and on serologic assays, really understanding the relationship between these 2 assays. looking at measures such as the incubation period, the proportion of individuals who are infected with SARS-CoV-2 that have symptoms, and potentially the severity and the fraction seeking medical care. And secondly, our second big pillar was really to understand the transmission dynamics of SARS-CoV-2 within the community and the household in particular, including the household secondary infection risk. And in fact, in this presentation, I'll refer to this as the household cumulative infection risk, which is really all the susceptible contacts in the house following a single infected case, what proportion get infected with SARS-CoV-2, and then other measures like the generation time, duration of shedding, and really just understanding transmission. And you'll see from our next slides, one of the real strengths of the first C study that's different from most other studies of SARS-CoV-2 is that using this quite unique and intensive study design, we're able to actually directly monitor and measure asymptomatic SARS-CoV-2 infection. And then in particular, in addition to understanding the contribution of asymptomatic infections, we were particularly interested in the effects of age as well as HIV. So I've made the design aspects a bit shorter to allow time for the results, but we can certainly discuss more later. But essentially, First C is a prospective household community cohort. It was conducted at 2 sites. The rural site is the Agincourt Demographics Surveillance Site in Green in Mpumalanga, next to the Kruger Park. And then the urban site is Jubiton Township in Klerksdorp. At each site, we randomly selected about 100 households, which gave us just over 500 individuals per site. Initially, they were selected from the previous first cohort, which represented a random selection of households from the community. And then we replaced with new households on the same sampling frame if we didn't have sufficient participants for First C. At enrollment, we would verify eligibility and baseline data. We took blood at baseline for serology to see if they had previous SARS-CoV-2. We took blood for HIV status determination, and we took a viral load and CD4 count for HIV infected individuals. And we had a detailed questionnaire, including information on underlying illness, habits such as smoking, contact patterns, sleeping patterns in the household, etc. And then once we had enrolled these people into our study, we followed them up very intensively for what will be 14 months at the end of August. So we started our intensive follow-up at the beginning of July 2020, and the intensive follow-up will end at the end of August. The data I will be presenting today are until the end of March 2021. And at every visit, we visited everybody in the household twice a week. The first visit was Monday to Wednesday, and the second visit was Thursday to Saturday. And when we visited, we took a mid-turbinate nasal swab from all the household members. And we also asked everybody in the house if they'd had any symptoms and if they'd had any healthcare seeking. And then overlaid on this twice weekly PCR test, we then took blood every 2 months to look for SARS-CoV-2 antibodies. This is just a picture showing the 2 sites. On the left, you see the rural site, and this is a typical setting. You can see the houses are fairly large, often brick houses, and there's quite a lot of outdoor space at the households. And in fact, we did many of the study procedures, in fact, in the outdoors. And then on the right, you see the urban site, which is quite typical of many of our urban communities, often very crowded. You can see there a sort of main brick house with some metal structures in the yard, very little outdoor space, a lot of the procedures taking place indoors, and I think quite typical of more urban communities, but you can see also quite different characteristics of the 2 sites. And this reflects, in fact, in terms of the SARS-CoV-2 dynamics that we saw at these 2 sites. In terms of the lab methods, we tested for serology using the Roche Elexis assay, which looks for the nucleocapsid antigen. And this is what is presented in this presentation. We are also doing an in-house anti-spike ELISA, and we are doing neutralizing antibody assays. And then for the PCR, we used the C-gene PCR, and we used the manufacturer's instructions, which consider a cycle threshold value less than 40 on at least 1 target as a positive. Because we were testing very large numbers of specimens from people who were mostly asymptomatic, in order to increase the specificity of our PCR, when we got a positive, according to manufacturer's instruction, we took a second aliquot from the same individual, we repeated the extraction, and we repeated the PCR 2 times. And we only included individuals who tested positive on 2 or more of 3 PCR runs as positive. We then performed for all PCR positive individuals. We did lineage or variant determination using the C gene variant typing PCR assay, which essentially, for the purposes of this, can distinguish the beta variant from the wild type and then the UK or alpha variant. And we are doing sequencing, but this is not presented in this presentation. Just one chart on the enrollment into the study. We approached 537 households. And then once we followed the inclusion criteria, which included that the house had to have more than 2 people in the house, because we were looking at transmission in the household, and that greater than or equal to 75% of people living in the house had to agree to participate in the study so that we could get a full understanding of the transmission in the household. Once we got people who agreed and who met the criteria, this left us with 222 households. In those 222 households, there were 1,249 people residing, and of those 1,189 or 95% of residents in the households under study actually participated and were included in the analysis. I just have one slide on baseline characteristics. Essentially, you can see that the age structure represents the age structure of South Africa. So a relatively young population, a relatively small percent over the age of 60, more children at the rural site, reflecting the underlying demographics of the community. Women were overrepresented within our sample, both in the communities, but this was exaggerated in our sample in that if anyone in the house didn't participate, it was often the adult male. And so the proportion of men is in our study is in fact slightly less than the communities from which these households were sampled. HIV prevalence of 15%, reflecting the prevalence in South Africa. And you can see this generally poor communities, a large percentage unemployed. Now, this is quite a complex figure, but it summarizes a lot of information from the study. So I'm going to go through it just a little slowly. On the left, you see the rural site. On the right, you see the urban site. If we start at the top with this little box at the top, just to orient you, the x-axis is time, and the study visits at the top and the dates underneath. And then the left-hand axis is the percentage of people testing PCR positive on each blood draw, on each study visit. This is a nasal swabs. And then you can see that tracked in the red line, which is the detection rate. You can see really on the left in the rural site, a very low percentage testing PCR positive for most of the follow-up period until the second wave. We have this really high second wave, almost getting as high as 10% and then coming down again. And then the right-hand axis really shows the cumulative attack rate or percent of people with evidence of infection, firstly only on serology in the blue line, and then secondly in purple on PCR. And you can see, again, very low percentage infected, and then with the second wave, a very big jump up until at the end of the study, between 20 to 30% of people at the rural site had evidence of SARS-CoV-2 infection. And then for the same figure, the urban site, so the same structure of the figure, you can see at the urban site, a much bigger first wave. And we started already when the first wave was ongoing, and in fact slightly after the peak in the first wave. And this is reflected also in that a number of people at the urban site were already seropositive at the start of the study. But then you can see a much longer sort of tail on the second wave, reflected in increasing seroprevalence, a low interwave period, and then a big second wave, and then again seroprevalence increasing until reaching between 40 and 50% in the urban site. So a really higher attack rate in the urban site. And I think this is reflected by the much more crowded and connected setting. If we then look at the middle panel, the middle panel is really what we call a mosaic, and it's really the way that we have of displaying a lot of the information on PCR and serology from our cohort. So in this mosaic, every row is a participant and every column is a study visit. And then the people in the same household are all grouped next to each other or consecutively. The block is sort of colorless or gray where we didn't get a swab for PCR. This light pink color reflects a negative PCR on the nasal swab, and the dark red represents a positive PCR. So you can see here a lot of negative cases, and then where you see these little red lines, these are people who test PCR positive, and if the red line is longer, they're shedding for longer. And if you see a whole lot of red lines all close together, those are very often household clusters of infection. And then we've overlaid on this the blue. The blue is those visits where we did a blood draw for serology. And the serology blood draw is colored light blue if the person tested seronegative and dark blue if the person tested seropositive. So if we start on the left in the rural cohort, at the beginning of the first wave, almost very few people were seropositive, so mostly seronegative you see, and there were very few infections. You see these spots of red. These are isolated infections, a few clusters in the first wave. These white bars are over Christmas period where we did 1 visit a week instead of 2 visits a week. And then you see just after Christmas in our rural site, probably because a lot of people came back to the rural site for Christmas, this very, very big second wave, lots of red, lots of household clusters. And then as a result of this, you see the blue, the seropositivity, the dark blue going up until in the last visit, you see quite a large percent being seropositive. And then on the right, the same story in the urban site, but many more people were seropositive at the start. You see quite a big second wave, a lot of cases and household shedding and clusters. Then again, the Christmas period, and then the second wave with, again, an increase in the PCR positives. And over the period, more and more people progressively becoming seropositive following their PCR confirmed infections. And then the bottom graph just shows the results of the variant assay, just to confirm for you that really the wild type was in green, was overwhelmingly predominant. And then in week 51, which is where we defined, you'll see for later analyses, the start of the second wave, which is around about here, this almost complete, very rapid replacement by the beta variant. And in the second wave, the period we defined as second wave for analysis, it was more than 95% of all PCRs tested positive for the beta variant. So just in terms of the follow-up, there were 76,940 potential follow-up visits in our cohort. And of those, we were able to collect and test a swab for 93% of those visits. And of all of those swabs, about 1% were positive on RT-PCR. But really to highlight, these are just individual swabs. They don't represent episodes of infection. What we are really interested in is in what proportion of households experienced a case of SARS-CoV-2 and what proportion of individuals. And you can see that here where almost 75%, almost 3/4 of households, and that's by the end of March of 2021, had at least one or more individuals who were SARS-CoV-2 positive. And in those households who had a case, the average number of people infected was 2.5 people. On an individual level, what we saw is that 34% of individuals, so just over a third, experienced one or more SARS-CoV-2 infections. This is confirmed either on PCR or serology or both. And just to show that in more detail, this figure just shows for each site by age group, the percentage who were infected by SARS-CoV-2 by the end of March of 2021. And the different colors reflect the different assays. So the black at the bottom is serology only. These were mostly people who tested seropositive already at the start of the study, but also a small percent of people who maybe we didn't get the PCR, but they did seroconvert. The vast bulk of them are confirmed both on PCR and serology. And then you have a little bit at the top who were confirmed only on PCR. And you can see this very characteristic age distribution with really the cases clustering in those middle age groups, 13 to 59 years, a lower attack rate in kids, but still really quite a high attack rate in children, reaching or exceeding 20% mostly, and then a slightly lower attack rate in the elderly, really showing what we've seen, that the middle age groups are sort of driving the transmission, older teenagers and young adults driving transmission in both communities, but much higher attack rates in the urban site. In terms of reinfections, we had 3% of individuals had a PCR confirmed reinfection. So of 406 people with at least one infection, 12 experienced a reinfection. We classified these, and I won't go into our classification in the interest of time, but one was confirmed, actually different variants proven, and the others were likely reinfections. We defined a reinfection as a possible reinfection as 4 weeks between the first PCR positive episode and then the second, and then a probable was 3 months, 90 days between the first and the second reinfection, and then the confirmed was 2 different variants in the 2 episodes. And this mosaic just shows our reinfected individuals. Then another interesting thing we could do was we looked at the protection conferred by infection in the first wave against reinfection in the second wave. So in order to do this, at the end of the first wave, just before the second wave, we classified everybody in our cohort as either having had a previous infection, and this is if they had evidence on PCR or serology of a previous infection, and then everybody else we called not previously infected, and then we followed them all up through the second wave to estimate the attack rate in these 2 groups of individuals. And we saw that people with previous infection had a 3% attack rate versus 18% in those without previous infection. And when you turn this around, essentially this translates into 84% protection conferred by infection in the first wave against infection in the second wave, in which the beta variant made up more than 95% of infections. And I think this is really important because this level of protection, 84%, is actually very similar to what was found in other mainly healthcare worker cohort studies in the United Kingdom and elsewhere, in which there was no beta variant. And so which found also 80 or 80, sort of low 80% protection from previous infection. So although the immunologic studies, consistently show a reduction in neutralizing antibodies against beta variant in people who were infected with the wild type, in our study, this doesn't seem to have translated into a reduction in protection. In other words, wild type infection seems to have protected quite well against beta variant infection. In terms of correlation between PCR and serology, essentially there was very good correlation with this very intensive sampling. So we had a subset of people who tested positive on PCR and who had negative serology before the episode and information after the episode. And the vast majority, 90% of people with a PCR confirmed episode did seroconvert. And there were no significant predictors of seroconversion. So a small percent of people who have PCR confirmed infection don't seroconvert, but it's a minority. When we look at the converse, amongst 265 people who were seronegative at baseline and then seroconverted, the vast majority, again, 87% had evidence of an RT-PCR confirmed infection. So essentially, with our twice weekly sampling, we were able to capture almost all of the PCR confirmed infections, but not 100%. And the ones that we missed could have been poor sample quality, maybe the assay is not 100% sensitive, and also there were, you saw in the mosaic, some people did miss some visits because of travel or other reasons. Now, just to go into a little bit of the multivariate analysis, this figure looks at factors associated with infection. So who was at risk of getting infection more? You see the urban sites had a higher attack rate. This confirms the middle age groups 13 to 59 had the higher attack rate. And then the only other interesting result was that people with obesity also had a higher attack rate. Interestingly, HIV, there was no association. Odds ratio was 1 for acquisition of infection. The other main sort of striking result in our study that really differs from the published literature is the symptomatic fraction. So we had 254 people with a PCR confirmed episode starting more than 14 days after follow-up. And of those, even though we visited them twice a week and we asked them about symptoms, and even when they were positive, we went back and told them they were positive, only 17% reported a symptom. So the vast majority of these infections which we identified were reported as being completely asymptomatic. And this is in contrast to the published literature, where really 16% would be at the extreme low distribution of all the systematic reviews. It really is much lower than what's in the published literature. And it's not clear really, does this reflect our study design, or is it something unique to our setting? Of those who were symptomatic, the commonest symptoms were cough, runny nose, a headache, very, very small number had fever and cough. But I think it's important to note, of the 43 people who were symptomatic, in fact, the number of them had quite severe illness. So a small number attended outpatient clinic, but 14% were hospitalized and 1 did die. So when disease is symptomatic, it certainly it can be severe in our setting, although obviously this is a community study. It's not designed to quantify severe infection robustly. If we look at factors associated with symptoms, really the main thing that came out was increasing age. So the older you were, the more likely you were to be symptomatic. But even in the elderly, only a third of individuals were symptomatic. There was no association with HIV or viral load. There was no association with previous infection, interestingly. For variant, there was the odds ratio for the beta variant was 2, but it wasn't statistically significant. So there may be an increased symptomatic fraction for beta variant, but we weren't able to demonstrate it. Moving on to the transmission and clusters within households. Again, repeat clusters within households were really quite common. So of households which had at least 1 cluster, 21% had 2, and we even had 1 household with 3 separate clusters or introductions of infection. And importantly, the overall household cumulative infection risk, and this is estimated as if you have 1 infectious case in the household, what percent of other household members who were exposed and are susceptible, in other words, didn't have a previous infection, acquire infection. And that household cumulative infection risk was 16%, which matches very much with the secondary attack rates that are published in the literature. Factors associated with transmission, very interesting. Age was not associated. There was no differential transmission from children. Symptoms were not associated. And what was associated was firstly CT value as a proxy of viral load. So low CT value or high viral load substantially increased odds of transmission. And then really importantly, obviously it will site, the urban site, which I think is crowded, and you saw the pictures, but then importantly, the beta variant with a 4 times increased odds of transmission with the beta variant compared to the wild type variant. So just in summary, by the end of the second wave, really a very high attack rate, more than a third of individuals infected, but with notable differences by site and age group, and a very good correlation between PCR and serology with this very intensive sampling fraction. Our symptomatic fraction was very low compared to the literature, and I've already mentioned that it's really, there aren't comparable data. No one's done a study like this, so it's not clear, is this a specific phenomenon in this urban and rural community of South Africa, or perhaps even extending to low and middle income communities, or is it something about our study design? And if you did the study in the United States or Europe, you'd see the same thing. Perhaps our young study population contributed, but I don't think it explains such a low symptomatic fraction. And then our household transmission, however, was really quite similar to the literature. And this is again interesting because the vast majority of index cases in our study were in fact asymptomatic. And certainly the literature suggests that asymptomatic people are less likely to transmit, although we didn't find that in our study. And there were no differences by symptoms or age, and the viral load was most important. Then importantly, we found repeat infections, and in contrast to the literature, we found that wild type infection, in fact, was very well protective against a beta variant infection. But we did find the beta variant associated with longer shedding duration. I didn't show that because of time, and also household transmission. And when you put that together, I think that this suggests that previous studies which showed the increased transmissibility of beta couldn't really distinguish how much was as a result of reduced cross protection versus increased transmissibility. But our study suggests the main driver is in fact increased cross protection. I think future work, we are doing neutralizing antibodies on all of our participants. And in fact, this is a very beautiful study design to be able to look at correlates of protection, because we have a collaborator who's developed a modeling framework to analyze these data. And you can really analyze in a very detailed level who's been infected and who's then been exposed, and whether their antibodies protect. We are following up until the end of August, so we are hopeful that we may be able to provide similar data on the Delta variant. Particularly important is the cross protection, and I think perhaps a quantification of transmissibility. And with that, just to really acknowledge many people, a huge amount of work, incredible number of study visits, and most importantly, the participants who really gave so much of their time to participate and have swabs collected and contribute to this study. Thank you.
Thanks very much, Cheryl, for a really excellent presentation and of this study that has been so elegantly and comprehensively performed to give us insight into what's happening in our communities with the epidemic. I think we've got time for 2 or 3 questions. I have one question to start out with, and I'm going to turn it to Mark to take some questions from the chat. But if I understand you correctly, you found no association between age and the risk of onward transmission. And there has been, some literature that has suggested that children are less likely to transmit. Do you think you had sufficient numbers to be able to conclude that that's not the case in our communities?
So absolutely. So no, I think it might be a power issue. So I don't think we can conclusively say children don't transmit less. We just didn't find evidence that they transmit more. I think one slide I took out because in the interest of time, and I think I already went over time, but so a very interesting analysis we did is we compared the index cases, so the person who introduced COVID into the home, to the characteristics of everyone else in the population. And when we did that, we found that children under the age of 13, so 12 and under, were significantly and at a low odds, like 0.3, so much lower, less likely to introduce COVID into the home. So our study, while it doesn't show that children are less likely to transmit on, it does show that they're significantly less likely to be the index case. So in other words, it's adults mostly who are bringing it into the home and then spreading it to the children, rather than children who are bringing it home from school and spreading it to the adults.
Yeah. Mark, are there questions from the chat that you want to put to Cheryl?
Yes, Graham, thank you. Cheryl, we've got a question about the difference in population density between rural and urban cohorts and whether that was quantified and had any potential influence on findings.
So we didn't quantify it. So the average household size was in fact similar in these two communities, which was 5. And no, we didn't quantify the population density, but just to say, we defined a household as people who who eat together and sleep together at least 3 times a week. And you can see in some of those urban settings, in fact, that was obviously a difficult definition to apply, but there might have been other people very close in contact who weren't within our household. So there could have been a force of infection from there, but no, we didn't quantify it. I think what site, however, was one of the strong covariates. In a lot of our models, there were site-specific differences, and so, I mean, we didn't directly measure those confounders, but absolutely, it does appear that there are site-specific important differences. I think just to mention, when we did our influenza study in the same communities, there were no differences by site, which was really interesting. So the urban and rural attack rates were very similar. So there is either something about COVID or perhaps the non-pharmaceutical interventions, and that it's perhaps easier to implement them in a rural setting where houses are widely spaced and in an urban setting, that's driving these differences.
Cheryl, just another question here about the 84% protection you report. Was that due to previous infection, or were there potentially other factors?
Yeah, so that's all previous infection. So nobody in our cohort was vaccinated. Essentially, I mean, certainly in that study design where we follow up, there could, I suppose there could have been confounding by other factors, but we did adjust for that in the model. But yeah, other than that, it's only really as a result of previous infection, which I think is somewhat reassuring. Certainly in Gauteng, a lot of people have had COVID, and so I think it suggests at least there may be some, some protection conferred by that infection. Although I suppose the big question, like when we did the study, Peter, was all the rage. Now Delta is completely replaced it, and so I mean, hopefully we'll provide some data on Delta, but who knows what will come after, I suppose.
And then perhaps just last two, which are on a similar theme. Would the communities differ in behavior because of being in a study? Would they have altered their behavior, stronger protection, maybe because they are aware they're being studied? And then a question from Linda Gale Becker saying, Cheryl, great study. Any way to see an impact of lockdown restrictions in terms of pattern of transmission? Thank you.
So I think really important questions, and I suppose it's a limitation of our study. We it's not possible to quantify. Absolutely, it must change people's behavior to have people come to your house and swab them twice a week. And we did inform people of their SARS-CoV-2 status, although it wasn't primarily diagnostic. So sometimes there were delays. I suppose what that means is these are minimum estimates. We did conduct a survey. So in our previous study, our flu study, we tried to measure behavior and those sorts of things, and we found it was just really so difficult to do, hand washing and isolating and whatever. So we didn't focus on that intensively in this study because it was just so difficult to quantify. But we did do one survey where we looked at whether people changed their behavior following a case of COVID and whether they're isolated in the home, and it seemed about 30% of people did report some kind of change in behavior. So this may have affected transmission to some extent. And I suppose, perhaps one should just view that in terms of, for example, the household transmission is a minimum estimate, it's difficult to tease it out, I suppose.
Thank you very much.
Okay, so thanks once again, Cheryl, for a great talk this afternoon. So we're going to move on to our final component of the webinar, and we've decided that rather than this be a presentation, it'll be a question and answer session. And it's a great pleasure to welcome Mia Malan to participate in the discussion this afternoon. Mia is Editor-in-Chief of Bekasize Center for Health Journalism. And she's had over 25 years of experience in journalism, working in newsrooms and media development organizations in Johannesburg, Nairobi, and Washington. She serves on the council of the South African National Editors Forum and holds a master's degree in journalism from Stellenbosch. Mia has really played a critical role in collating up-to-date information and metrics about the SARS-CoV-2 epidemic, but also the vaccine program in South Africa. And writing about that on the Bekasize website, writing about that and collating the information on social media, as well as participating in radio interviews. and really has been a reliable and up-to-date source of this information across South Africa. So I'm really excited to welcome Mia this afternoon to participate in this discussion. So welcome to you, Mia. Thanks very much. So we've kind of put together a question and answer session, and we're going to kind of do it in the format of focusing firstly on what is happening currently, and then look back in the past as to what's happened with our vaccine program between 2020 and 2021, and then look forward in the final section to what we can expect with the vaccine program going forward. So Mia, I firstly wanted to ask you if you can just give us an update on how many South Africans have been vaccinated to date, and the various mechanisms through which they have been vaccinated in terms of what vaccines they've received and the access routes.
Thank you, Graham. So I'm fully vaccinated, so people who've either received 2 doses of Pfizer or 1 dose of J&J is around about 1.5 million people, and that comes to about 3.8% of the vaccinable population, people of 18 and older. And of those people who have been fully vaccinated, about 600,000 of them were fully vaccinated with Pfizer, and just under 1 million fully vaccinated with J&J, and that of course includes all the Sisonke study participants. And if we look at who has received 1 dose of Pfizer only, that's about 7.8%. And while I talk, I'm going to give you a link in the chat box, because the tracker of the health department doesn't give proportions, and we've taken that information at BKCSA along with another organization. It's in the chat box now. And we do the proportions every day to show people, you know, what proportion of people of 18 plus have been fully vaccinated. I'm sure all of you know we only use 2 vaccines at the moment, Pfizer and J&J, and how people access it is through primary healthcare sites, private and public sites. And there's also essential worker groups. Now, everyone who goes to sites only gets Pfizer. No one gets J&J at this stage. And the reason for that is because the vaccines that we've received, J&J ones, all expire on the 11th of August. And we rather use it for essential worker groups where it can be used up relatively quickly so that they don't expire. And the groups that are getting them at the moment is school staff, so primary school and high school staff, teachers, everyone who works at a school. In the private sector, it's often only the teachers. And correctional services is also busy with a program. The SANDF has just started. Journalists will soon start. We've just given all our names and submitted it, so it shouldn't take too long for journalists to start with getting J&J. And the social development department will also start soon. And then there's also workplace programs that many people actually don't know of. So in mines, mines are vaccinating their people, not all of them, but quite a substantial number at the moment. Even in the taxi industry, there are 2 sites at the moment where taxi operators are getting vaccinated, all with J&J. And then there are community programs, things, for instance, like SASSA payout points for people of 60 and older. That can't happen right now because of the unrest and the cash in transit industry that don't feel comfortable to take the money to pay out points and feel that the people who receive it won't be safe. The South African Medical Research Council has a project like that with mobile vans in the Sikisiki in the Eastern Cape, in the rural Eastern Cape, and they've actually been pretty flexible. They've now taken those vans and they've gone into communities because obviously there's not going to be anyone at a pension payout point to vaccinate, and they really are going door to door to get people, older people, to vaccinate. And that's pretty much how we access vaccines. I'm not aware of other points. Obviously, there was a Sisonke study for the health workers, and then there were a few people, other groups who received some of the doses that were left, like sports people and that sort of thing.
Yeah. So, Mia, then the next question, just in terms of the rate of vaccination and you know, whether we're seeing, and obviously we need to scale up rapidly to increase coverage, and one of the limiting factors has been vaccine supply, but are we currently picking up in terms of the rate of vaccination?
The last week, over the past 2 weeks, I'm not counting this week because this week is different, but we really did pick up. You know, you would, particularly last week, you would see increases of 20,000 vaccines more the one day than the previous day. We reached the most vaccinations that we reached per day was 191,000 on Thursday last week. And that has now sadly gone down significantly because of the unrest. And that's mainly because we have so many sites closed in KwaZulu-Natal, and they contribute quite a significant number of the national number of vaccines. Last week, they did about 40,000 vaccinations per day. So if you look at the figures this week, yesterday it was 146,000. A large part of what we now don't have that's lower than last week is because of this. It's very ironic that this unrest and the reduction in the number of vaccinations is happening at a time where we've been in the best position since the start of our rollout in terms of supply, and now we can't use all of it. Some of the KZN doses are being redirected to other provinces at the moment. The health department had an aim to increase to 250,000 vaccinations per day by the end of this week, which is obviously now not going to happen because there's also a few sites in Gauteng closed. And I would also think that the impact of the unrest is not just on can we vaccinate or not, but it's on COVID in general. It is chronic medication in general for comorbidities like diabetes and HIV and hypertension that can't be accessed, and also huge problems with getting enough oxygen to hospitals because the oxygen companies feel unsafe to go to hospitals, so they need to find different routes and they require police escorts. So if you look at social media, there's a lot of reports of doctors saying the oxygen supply is running low at their hospitals. So it's really a bigger, I think the fact that we can't have some sites open in KwaZulu-Natal is almost a smaller problem than all the people in KwaZulu-Natal who can't access their chronic medication.
And just, I mean, do you have a sense of how many vaccine doses are in South Africa currently that have not yet been used?
So the health department hasn't given figures this week. They have a press conference every Friday morning, and then they generally give those figures. So last week's figures was that we had 18 days stock of vaccines. That was around about 3.5 million of vaccines, but we have received more since then. We have received 500,000 Pfizer doses over the past 2 weeks, and we're getting another 700,000 this coming Monday. We haven't received any J&J. We've only received 1.5 million J&J doses. They were supposed to replace the 2 million doses that we couldn't use because of the contamination issues. And they still owe us 500,000 of that. In addition to that, they haven't given us any delivery dates. I spoke to the health department this morning. They don't yet have dates for when would the J&J stock arrive. We also don't know, there was Aspen that fills and finishes some of the J&J doses. Some of you may have heard on television about 3-4 weeks ago, Stephen Saad, the CEO, said they were going to give 1 million doses. It was shortly after the FDA's announcement, and those doses were never released, not to South Africa in any case. And we just don't know when they would arrive. We also don't have data. The health department hasn't received numbers from J&J as to how many of the 17 million doses that the president announced in his recent address that Aspen would be filling and finishing on the site over the next 3 months. We don't know what proportion of that we'll get.
Mm-hmm. And you know, in terms of the kind of significant challenges to scale up, you know, we've known that, you know, the constriction of vaccine supplies has clearly been a problem for many months, and now you've spoken about the violence in KwaZulu-Natal and Gauteng. Just other challenges that you think currently exist to scaling up to the target numbers, you know, those two issues aside?
So obviously there's been weekend vaccinations that many people have been complaining about, and the health department's response to that was that they didn't have enough vaccines and that they didn't have a budget to pay health workers to work overtime. So there's a budget for that now. On the 1st of August, they're going to scale up. They're already scaling up a little bit. This past weekend, we already saw more weekend vaccinations than previously. For me, as someone who reports on the vaccination rollout, the biggest challenge has been communication. And I think that is also part of how this vaccination rollout started, with a lot of feelings that there wasn't transparency. And so for me, the challenge is that the information isn't freely available. Even as a journalist, you know, you can't go through the formal health department channels to get information, you will wait for days for it. So you can't go to the spokesperson and say, give me this, you'll get it in a week's time from now, unless you know the people personally high up and you can WhatsApp them or you can call them, you wouldn't get that information. And that's not the way to run a campaign where some people may already be hesitant and where people are anxious when they don't get access to the vaccines that they want. So for me, that has been the challenge. You know, I deal with these health department people a lot. I really don't find them, most of them I find very hardworking, very committed, and very competent at what they do. It's the communication of explaining to people what they do and why they do it or why they don't do it, that I think creates a lot of mistrust around the campaign and a lot of anxiety among people because they don't know when what will happen.
Thanks. So I now want to move on to discussing some of the past issues with respect to our vaccination program. And there have obviously been, you know, major delays in getting it up and running initially and then scaling it up. And just kind of high-level summary of what you think went wrong, both, you know, internally with respect to the procurement decision and then the external challenges that the government faced, and what could have been done differently from the second half of 2020 onwards.
So obviously, I mean, what everyone has been talking about was that the health department started to procure at a very late stage in terms of bilateral agreements. And the reason for that was twofold, I think. And the one was that the Ministerial Advisory Committee wanted to first wait for results and see what is the efficacy results. And I know there was a feeling that we need a vaccine that with quite a high efficacy, if we look at how many people we're able to reach for herd immunity in the country that we may not be able to reach, like 80 or 90% or a very high number. The other reason they say they waited is because they waited for COVAX, of course. They wanted to show solidarity and access vaccines via COVAX. Now, I am not an expert or a scientist or a doctor like many of the people who are probably watching today, but from the interviews that I've done, I understood why they wanted to wait for the efficacy results and wanted to see which vaccine would be best to buy. I think where they did have doubts about their strategy afterwards was, should we have waited for COVAX only? Because even though you wanted to show solidarity and use the mechanism that the World Health Organization came up with, the reality was that you knew that everyone else was going to have bilateral deals and it wasn't going to work that way. And ironically, we then bought AstraZeneca vaccines, which was really part of COVAX stock. The Serum Institute in India, you know, was contracted to produce AstraZeneca doses for COVAX. So then we sort of broke our own rule and we went into a bilateral deal. And the reason we bought the AstraZeneca is really because it's the first company, you know, it's the only company that could give us the vaccines the fastest, that we could. If you recall, Pfizer could only help us in April. And if you look at this year, you know, we received Pfizer at late stage. So I think they're waiting for COVAX and assuming that it would just work is perhaps something that should have been reconsidered. Ironically for me, when I look back, is that there was a lot of pressure, obviously, on the health department to buy vaccines when people realized we didn't have any. And they then rushed to buy AstraZeneca vaccines. And ironically, if they had started earlier with bilateral procurement, they would probably have procured AstraZeneca. And then we would have had millions and millions of doses of a vaccine that wouldn't have worked that well against mild to moderate COVID. I know there are many arguments to be made for the severe COVID part. So that is it. And I think, you know, if I, again, look back, I think if the health department communicated better and kept people abreast of each step of thinking along the way, I think there would have been a lot less anger and a lot less anxiety. Because when I, as a journalist, interviewed people in the Ministerial Advisory Committee, it comes across as a pretty rational decision. It doesn't come across as if there was conspiracy or people who wanted to do secret things. It was a pretty logical decision that, you know, wait for the efficacy results. But when it comes across to the general public, it comes across totally different, because it wasn't communicated step by step. You only hear about it when there's so much pressure and people are so angry that there's all of a sudden a television broadcast and the health minister tells people what's going on. And then often the level of information presented during those things are from scientists that the general public just doesn't understand. So communication, and we of course know that there is not a big capacity for communication in the health department at the moment because of the whole digital vibes thing. So there's 150 million rands that was used for communication that they no longer have. And most of those communication services were out contracted. So they're now in a position where they have to find resources to communicate that I don't know where they're going to find the money from, but where not even just the money, the capacity was just not there because it was contracted out. There's just no internal capacity to communicate that well. And so it is a bit of a mess when it comes to communication. And I think the acting health minister, actually, because she comes from a communication background, has increased that a little bit. It made it a little bit better, but she's also quite aware of the lack of the department to communicate at the moment.
Mm-hmm. Just to go back to the issue of the sort of failure to enter into bilateral discussions in late 2020. I mean, they obviously made a political decision to go with COVAX, but there were so many other countries of similar socioeconomic status that were having those bilateral negotiations. Do you think they made an active decision not to do that for political reasons?
I don't know if it was political reasons. I know there was a decision to show solidarity and to support the mechanism that would give middle income countries access to vaccines. I, sometimes get the impression that decisions aren't necessarily that strategically planned at the health department. There's so many crises that some of these decisions, are just sort of made on the spot of something. So I don't know if there was as much planning as you think into make a political decision. I think lots of these things just happen at a time. But I do think there was a very deliberate decision to wait for efficacy results, and that was from the Ministerial Advisory Committee. That was not necessarily, other people's decisions. Yeah.
Okay, so then to move on to looking forward into the future, where we expect the vaccine program to be going. I mean, you've told us that it's the Johnson & Johnson and the Pfizer vaccine that are currently being administered. Do you think that other vaccine options will become available within the next few months in South Africa?
My feeling is that they will, because I think the health department is realizing very clearly that if we rely on 2 vaccines only, that is risky, because look what happened with the J&J vaccine that we still don't have, the doses that we need. And that even though between J&J and Pfizer, we've bought enough doses to vaccinate everyone of 18 and older, that's not necessarily the best strategy, because what if there's a crisis, a manufacturing crisis again? So there are 2 vaccines that they definitely looking at, and that's AstraZeneca and Sinovac. My feeling, I do not have information from the Ministerial Advisory Committee or from the health department. It's just in my conversations with people from the health department. I get the feeling that AstraZeneca is definitely considered because of the Delta variant and its efficacy. Perhaps more so than Sinovac's vaccine. With Sinovac, it has conditional emergency authorization, and I think they're still waiting for information on how effective it is against the Delta variant, where with AstraZeneca, we've got that information. But I do think, I actually spoke to someone, Nicholas Crisp, yesterday, and he definitely gave me the impression that they are looking at, that they are definitely strategically considering having at least one other vaccine. And obviously the 2 vaccines that have been approved is Sinovac and AstraZeneca. So that would be the 2 to choose from. And I get the feeling that they may be leaning more towards AstraZeneca.
Okay, and then just a kind of broader question on a global level. I mean, in terms of global manufacturing capacity for vaccines, I mean, that has been scaled up. And do you think that, we could realistically expect sufficient vaccine globally to vaccinate the world's population by, for instance, the end of next year, or is that too optimistic?
So I don't have a clear answer for that because I haven't studied those numbers intensively. But what I can say is it depends on so many things. It depends on whether there's going to be a booster dose for any vaccine and whether the Western countries are going to buy it up again. It depends on, we've already seen sort of like ethical issues like, teenagers and being vaccinated in the United States and elsewhere. And soon it might be kids because they're busy with results for that. And it depends on whether it's going to be considered okay for if there's booster doses, if the first world basically is going to take it all for themselves again. I think it depends on how many other companies get licenses to produce vaccines. So not necessarily from start to finish, but just fill and finish like Aspen does, because that also speeds up the process and how willing the companies would be to issue licenses. In terms of manufacturing in South Africa and elsewhere, that's not going to happen very soon. Even if you look at the World Health Organization mRNA hub that will be set up in South Africa, they plan to set that up over a period of 2 years. It's not going to happen very soon. It's not going to be finished very soon. And Moderna's CEO has said that if they had to transfer technology to teach people how to do mRNA technology, it will take at least 6 to 9 months to do that technology transfer. So even if we get a World Trade Organization agreement of, like intellectual property rights that are waived, that's still not going to solve the problem. There's going to be all the technology transfer situations. And I also think, obviously, variants is going to play a role. It depends on whether our vaccines continue to be effective against new variants. And from all people like you, scientists and doctors, you're pretty certain that we will see more variants emerging. And I think it will all depend on whether people are then properly vaccinated or not, and whether we need more vaccines or more boosters to protect them. And that will determine whether everyone in the world is vaccinated at a certain date.
Yeah, and Mia, just in terms of the, you mentioned that South Africa's vaccine manufacturing capacity, that's really something that's not going to help in the short term. My understanding is that it will take too long for it to kind of be sufficiently developed to actually manufacture vaccines in South Africa. Is that correct?
Yeah, we've done a few stories on it, and I've spoken to BioVac and African Biologics would be the two companies that receive technology transfer for the mRNA for the World Health Organization hub. But even BioVac is very sort of like we're transparent about it. They're not near or even close to being able to produce these type of vaccines. We haven't produced vaccines from scratch since for 20 years, basically, in South Africa. So to develop that technology is something that will take years. I think the general feeling is that mRNA vaccines would be more doable than other types of vaccines because the process can be divided almost like into modules, and you can produce different parts of the vaccines at different companies. So that might be more doable so that you only do one part of the manufacturing, or that you don't have to do all of it. But no, I think we're very far away from. It's interesting for me when the president gets so excited and say we must produce the vaccines because it's so far away from happening. And I think it's a very complicated process to understand why it is so far away.
Yeah, I mean, clearly it's something that we have to do as a country to rejuvenate that capacity, but it's not going to help us in the short term with respect to the COVID vaccine program, it seems, yeah. So, Mia, I just wanted to check with Mark Sondrup whether there are any questions that have come in through the chat.
Graham, nothing as such. I think Mia has stunned everybody into silence. Yeah. But could I be parochial and ask a question?
If please do.
Can I have your thoughts on what you think we have done wrong and what we continue to do wrong, potentially, to push back on vaccine hesitancy? What do you think we could do better going forward? I'm saying this because I'm rather startled from my own perspective in the range and breadth of people I'm coming across at patient level who just seem to be extraordinarily vaccine hesitant. And I wonder what we've done wrong.
Okay, I'm just going to tell you what comes up in my mind. It's, you know, I might need a little bit more time to think about it. But the one thing is, in all the studies that you look at that talk about how do you address vaccine hesitancy and why do you have vaccine hesitancy, something that comes up consistently is that the provider of the vaccine, so in this case, the health department, how much people trust them is a very strong predictor of vaccine hesitancy, how willing people would be to take it. And because our communication has not been consistently good, I think that is something that if we improved on that, I think more people would be willing to take vaccines. I just look at people, middle-class people who have access to internet, who can check Twitter, they should have access to information. There is so many basic things that they don't have. For instance, when the health department changed its policy from removing comorbidities as a category that would be prioritized for vaccination. Initially, it was a category. I still see people on social media not knowing about that because there was no press release issued. There was no campaign. You know, it shouldn't just be press releases. It should be posters in 11 languages that's released and explained to people how those things work. And then I also think that when we don't really have campaigns to counter vaccine hesitancy, but when we do have them, they're going to have to be targeted and based on study findings that have been conducted in South Africa. And one example would be that with the NITS-CRAN study, they found that Afrikaans people were, for instance, particularly hesitant. I'm Afrikaans, and I find it in my community as well. And that, for instance, in the Western Cape, you would need to have Afrikaans campaigns so that you target the people who are most hesitant. And I don't think we're even at the level where we're going to target people. I think we're at a basic level where we just need to figure out how to communicate. And we obviously only going to see the levels, I think, of hesitancy. I mean, I know you see it, Mark, as a doctor with your patients, but generally countries only seem to figure out how real vaccine hesitancy is once they reach quite a high vaccination level and then struggle to get more people to get vaccinated, like the United States at the moment. And obviously in South Africa, everywhere, studies show that politically conservative people are generally more hesitant than progressive people. Interesting that, you know, people who support Trump in the US are more vaccine hesitant, same sort of tendencies you get in the UK. And we may want to consider, you know, looking at those communities for targeted campaigns as well, perhaps, yeah.
Thanks very much, Mia. Cheryl, I think I kind of thought extracted your question. Is there something you wanted to add on?
No, not at all. Thanks.
And Mia, the indications that vaccine hesitancy is reducing in South Africa, are those surveys reliable, do you think? And are we going in the right direction?
So the NITS-CRAN study, I think, is a reliable survey. You know, I think it's good. And I think it is consistent with what's been found in other countries, that as soon as you start with a vaccination campaign and a vaccine becomes sort of like a hot commodity that people compete for because you go down ages and age groups and that sort of thing, then more people are willing to take a vaccine. It's gone up in the United States when they started with their campaign. In the United Kingdom, the same thing happened. So those results that they're finding is pretty consistent. I think the next level is now when we've vaccinated a lot of people to see what happens then. And obviously, if we haven't had any reported deaths or very, very bad side effects, that's been very public. And if those stories start to circulate, I think they go pretty far on social media. And that's why I feel very strongly that because social media, particularly Twitter, is such a channel of misinformation, that's exactly the channel that you should work to and use to spread the correct information. You should use exactly the channels that the people use to spread the wrong information, to spread the right information. And we can now just see what happens. I really hope that with more doses arriving, is in at least for Pfizer, we have dates for delivery for the next month or so. I really hope that it does scale up, obviously without KwaZulu-Natal's figures, and that people start to share their experiences with each other. The other thing that I can't remember in which study this was, it was a South African survey, it might have been Sisonke even, where they said that once people had seen other people who were vaccinated, who were healthy after a month or so, the people who were hesitant, so not anti-vaxxers, but people who weren't sure if they were going to take the vaccine, were far more likely to take it. And that community leaders, I think that was in the NIDS-CRAN study, that the best way to try and convince people to get vaccinated is through community leaders. They asked people the question, what would make you, if you didn't want to take a vaccine, take it? I think they took the group that said they weren't sure and then asked them that question, and they were community leaders. And we see it in South Africa at the moment, in Limpopo. That is the one province that used community church leaders and traditional leaders to get people to register. We've seen very high registration rates in Limpopo, and also a high take-up of vaccines. And if you look at the figures proportion-wise in South Africa of which province has vaccinated the most, KwaZulu-Natal is pretty much ahead, but Limpopo second. And it's a very rural, you would think in this rural province it would be hard to reach the people, but they've used the community leaders so strongly that there's been really quite a very good uptake of vaccines, and we should really consider doing that in other provinces as well. Use community leaders, I think.
So it's really an issue of trust and people that you trust in terms of the information that they're giving you. Are saying, it's something that should be done. I think when people follow, and the optics of seeing people in a queue, as opposed to it being a theoretical discussion, once people see people queuing, I think that those optics encourage other people to join those queues. Mark, I don't think there are any other questions. Is that correct?
That's correct, Graham. I think we're done.
Okay. So then just to wrap up, to say that, thanks very much to Mia for a very enlightening discussion. As always, extremely informative and up to date in terms of the data and information on our vaccine program. And just more broadly to thank you for the role that you're playing in filling up some of those information gaps. And really, I think I speak for many people to say that we value the information that you share through Becca Caesar and on social media, with the updates on the vaccine program, which are really a reliable and valuable source of information. So thank you for that. And then just to thank Cheryl and Erna once again for their inputs today, and wrap up what's been a very informative and valuable webinar. And our next ECHO webinar will be in around a month's time. We'll send out an advert for that. Thank you very much, Mark.
Thank you, Graham. Thank you, everyone. We'll see you next month, hopefully in better times. Thank you.